Good morning, panelists. Thank you for the opportunity. So at the outset, I would like to introduce my team. On my right is Dr. Kailash. He is an intervention cardiologist. Dr. Govind Sharma, intervention cardiologist. Dr. Prashant Varshne, he's a cardiac anesthetist who takes care of all our TIV, mitral clip, and all structural patients. We have our technician, Sandeep, and we have Boston as well as Edward's team. So our plan is to do a cerebral protection TIV. So let's go to the first slide. Next one. Next one. This is the place where we work. This is our team. Next slide. So it's a young patient, 58-year-old female, presented with NYHA class 4, post-renal transplant in 2008, had a graft dysfunction since 2014. Patient was on high dose of steroids, now again on an end-stage renal disease, on maintenance hemodialysis since 2014, diabetes, uncontrolled hypertension, sinusism, anemia, dyslipidemia. Next slide. This is the ECG, normal sinusism, LVH pattern, narrow QRS. Next slide. Patient also has mitral annular calcification, mean gradient is 6 of the mitral valve, peak gradient is 11. Severe calcific aortic stenosis, aortic valve area is 0.7. The DVI is 0.2. Mean gradient is 40, peak gradient is 60. And you can see from the tracing, this tracing is obtained from the right parasternal view. And you can clearly see this patient is surgical turn down because of prior renal transplant, steroids, MAC, and multiple other comorbidities. Next slide. The STS score, mortality 7.6. Next slide. This is the CT scan. It's a tricuspid calcified valve. Annulus area is 442 millimeters square. Area derived diameter is 23.7. Perimeter is 76.2. Good coronary height, LCA, RCA 13 and 17. Next slide. And this is the angulations, which is LAO 27, cranial 1. Next slide. Femoral vessels, all vessel size, the vascular size is more than 5 millimeters. Next slide. Our plan is a conscious sedation TIV, right femoral access for TIV, cerebral protection with sentinel device. We'll use one ProGlide and one angioseal post-procedure. Valve which we have selected for this case is a 26 millimeter Edwards Sapien 3. Next slide. Next slide. We'd also like to highlight our data, which is almost now more than 200 cases in Jaipur. The average age of the cohort is 71, MyValve 63, Evolute R 64, and Sapien 73. So we have almost 1-to-1 valve experience. Next slide. Next slide. I'm not going to waste detail in that, but the procedural outcome, the pacemaker rate is 1% for the balloon expandable MyValve, 3% for Sapien 3, and Evolute R 4%. In hospital mortality, we lost 2 patients in the self-expandable group. Next slide. And this is the outcome of our center starting from February 2022. The total transcatheter valves replacements we have done is 101, TAVR 93, TMVR 6, pulmonary valve 1, trach valve 1, and 14 mitral clips. Next slide. So we're going to start our case, sir. We can have a small discussion if you want. We have a 14 French E sheath on the right side with one ProGlide. On the left side, 6 French femoral artery, 6 French vein. And we're going to do sentinel from the right radial. Can we focus here? Show the arch angiogram. And can you see the angiogram there? You can see calcification at the ostium of the brachiocephalic artery. And you can also see the origin of the left carotid, which is from the arch. Okay. So this is the sentinel device. And we're using an 014 wire. So the preferred wire is a BMW. Okay, let's see. Advance the wire. Okay. And we have a 6 French right radial axis. We might face some challenges here because you can see there is some tortuosity. Okay. So that's the descending aorta. We're going to come down, cross. Okay, so we're going to come to the ascending part. Pull back the pigtail to the ostium of the brachiocephalic. And then at this point, you can see that linear line. That is the first proximal filter. We're going to deploy the proximal filter. Fluoro save. We're going to go ahead and flex. Okay, you can pull back the wire a little. Going to torque it. Advance the wire. That's the left carotid. And then deploy the distal filter. It's going to pull back further.
Probably do the separate second one a little bit more. Yeah, that's good. Yeah.
Yes, yeah, so I did that, and now we're going to lock it. Okay. And then just do a small test whether it's going to interact with the pigtail or not. Okay, fluoro save. So once that is done, we lock the device. Let's put a sheet on it. Okay. Go down, show the arch, and now show us down.
Ravinder, are you doing Sentinel on all your cases or just some of the cases?
So I offer to all the patients now, because it's an out-of-pocket expense, and now we have done it with mitral valve, with the aortic valve. If there is a financial challenge or an anatomical challenge where I'll not be able to deploy my filter, in those cases we're not doing. But now I'm offering to all the patients. What's your practice, or maybe you can have some comments?
Yeah, Ramesh asked that question.
That's an
in
AL1.
The morning where when we were doing a workshop. And our challenge is obviously the economics behind it. In the US at least, there's no funding mechanism for it. And then the second is I'm still not 100% convinced of the data and what subsets to use it in. Sushil, what's your view on this? Are you 100%?
Yeah, I mean, we do it routinely. I mean, part of my issue is it's an accessory device, and I think one important component, the device has been shown to be very safe. So, and it does capture debris. But you raise the point, it's a cost issue. Is there clinical benefit? And, this fall we'll have the data from Protect TAVR, which will hopefully help answer some of the clinical question of stroke reduction. But my attitude has been, if it's safe, I'd rather capture the debris. I agree it's not an ideal device, that we don't have ideal data. And there'll be other devices coming down the road. Hopefully we'll get better data, but I think stroke is one of the most important things, so we got to try to continue to reduce that rate.
Yeah, I think, Dr. Kodali, those are very important points, especially when we are practicing in India where people are paying from out of pocket. And actually now, because there is so much of awareness, we come across patients who would ask for a cerebral protection device. And then I think you have more experience, but I think the first study was comparing stroke outcome at 30 days. So I think once we have new data, which would be at, once we have data at 24 hours or 72 hours, I think that is going to make a difference.
So it's a very difficult...
We have a safari wire. We have selected a 26. Yeah, go ahead.
Yeah.
Val, please.
Yeah, for cerebral protection, it's very difficult to answer whom you will not, or how do you choose the patients. Is there a clear evidence? Absolutely not, right? It's not like, still probably in 200 cerebral protection, we always try to look for macroscopic, they can't find any macroscopic emboli. There is probably microscopic emboli, and the MRI studies definitely show a decrease in or increase in diffusion weighted images showing more infarcts if you do not use Sentinel. So that said, at least in our institution, as I mentioned earlier, calcium score more than 2000, and we're tight valves less than 0.6. And if you're doing BAVs and
cranial?
multiple times, then we would definitely protect
that's
that brain. Younger people. But now, I think we are also using in more and more sentinels in general.
Ramesh, actually it is true for
So
even
now
carotid
we have a
interventions
26
also.
yeah.
We may not see anything there, but actually we have to use it.
Okay, feed the wire. So this is a 26 Sapien 3, and we are mounting the balloon inside the valve. So you pull back, and then we do some fine adjustments. So make sure you go AP cranial, remove the parallax from the valve frame, and then align the proximal and the distal markers with the top end and the bottom end of the frame.
I think as my valve is little thicker French,
save.
but this all thing is pre-mounted on that, so that these steps are avoided in that. But only thing is the French becomes bigger, and that's difficult to be done.
And some of the newer generation
So go to
Sapiens
LAO.
also have that ability. I think the next generation
So
will
that-
actually be pre-mounted.
With Python sheath and
keep a
E
watch
sheath, I
on the
really
wire.
don't find any difference. Even though it's a larger Python sheath, I think is
Show me
very
above.
easy to use as well. Of course, you might have to push it in a little
Okay,
bit.
fluoro save. So we're going to go ahead and cross.
And this flexion the possibility of delivery in
Okay.
Edwards.
Fluoro
I think
save.
now I was told that even the Medtronic has launched a new product which we are having live demonstration where the flex thing is possible with that thing. I think a Protect Tower is
Now
a
you
randomized
pull back
trial
the
going
pusher
on with Sentinel
to this.
versus no Sentinel in US. Protect Tower, I think randomized trial, they're planning for 1800 patients or so. I think results are yet to be presented in this TCT, I was told.
Yeah, that should give the answer.
Let's
My
have an
challenge
allogram.
with the existing data set is that
Inject.
it just has a higher stroke rate than we're used to seeing in clinical practice in baseline groups.
So we are ready to deploy the valve. Can you guys see the position?
It looks fantastic.
Okay, so we'll pace at 180. Okay, pace at 180, please. Unlock it. Inject. Start going up. Yeah, go up. Fully deploy. 1001, 1002, 1003. Deflate. Okay, stop pacing and fluoro save. Gonna walk out this part. Okay. Okay. Okay, remove it. Okay, let's have a pigtail, please. So, we come across these type of patients in our clinical practice, patients with mitral annular calcium, MAC with mean gradient of 6. How do you handle such patients? You do only aortic, or something needs to be done for the mitral?
Ravinder, this is,
ahead, picture,
obviously
please.
patient with end-stage renal disease. I don't think, there is anything to be done for the MAC. Mitral gradient is only 6.
Yes,
I
agreed.
would medically manage for the time being. And in people who have much higher,
So-
obviously we are enrolling patients in Tendine in MAC, but that's only in case if they have severe MS or severe MR or moderate MS and moderate MR.
No, yeah, I think that's fair. The reason I asked this question is we come across this question from a lot of referring physicians and cardiologists that such patients need to undergo both the valves. But I'm telling you, such patients, if they undergo both the valves, they're going to be having a poor outcome. So until unless patient is operable and low risk. Come, Caudal, remove the parallax. Okay, good. Ready for injection? Okay, can you see the hemodynamics?
We can.
There's no gradient, there's
No
some
gradient.
trivial regurgitation. So we're going to go ahead and remove this pigtail. Okay. Okay, ready for one more injection? Let's see. Inject. Yeah. Okay, so I think from the valve part, To me, it looks very good. There's some just trivial regurgitation that's going to go away. Patient is still in sinus rhythm. Diastolic pressure is 90, and there is no peak-to-peak gradient. The valve which we chose was a 26 millimeter valve. And
So what's interesting is the trial with the next generation Edwards X4 valve is ongoing. One of the features of the next generation valve is, this is a patient with an annulus of 440, which is sort of on the significant oversizing for a 26. The next generation is going to have the same valve based on volume can be incrementally sized. So you could put a 24, which is probably what's necessary here, and not a 26. My valve has taken the approach, they have intermediate sizes. The Edwards, with their next generation, is going to have variable sizing to cover the range. And so you can deploy the valves at 24, 25, 26, and the leaflet function should be okay. And that valve will also have commissural alignment. So, we had a chance to do a few cases, trials ongoing, so it'll be interesting. So hopefully we continued evolution of this design.
so we're going to go ahead and capture the filter. So we're going to capture the distal filter first. You pull back, take it inside the vessel, push down a little, unflex it, pull back the wire, keep it on the soft portion. Okay. I'm going to pull back, lock it, capture the proximal filter. Okay, hold it.
No, I think one is not captured yet, right? And
Yeah.
the basket one is not captured, proximal.
Yes, so we're going to do that again.
Might be stuck on the calcium.
You said you have to remarry the back portion because it won't be. So you just have to advance the wire out and then push the back portion forward just to give room for the filter to be captured.
Yeah, that's like, I always keep the wire out a little bit.
The back end has to be pushed to the two plastic portions have to be married together. And then that gives you room for the proximal filter to be captured. Now that's perfect. Now you can recapture.
Yeah. Okay. We're going to lock it again, and then let's see the show me the proximal part.
You're not able to capture that one, the number one?
Capture.
Yes.
Okay.
So push you gotta push that forward now. Push that forward.
Yeah,
There-
now
there you go.
recapture,
you
right?
can
Got it.
recapture.
So captured it. Yeah. So that's a problem with the tortuous and that calcified segment. And then you maintain the forward pressure on this knob and then pull it out. Okay, so now I think we have time. We're going to go ahead and show one ProGlide and one AngioSeal as well.
People like to see whether you captured anything
Come
in the
down,
filter.
please.
Can you focus on that? Any material is there in that filter?
We will show. Yeah, we will do that. Let's see. Let's do that filter, please. Okay.
I think, Ravinder, you did a great job of demonstration of Sentinel in this case, and balloon expandable valve simplicity of deploying also you've shown it enough. You did it in shorter time than angioplasty. Congratulations. I think closure devices, we can see it further, but if you're okay, show us the filter, then probably we'll move and
We will.
come
So
back.
by
No,
the time,
actually, I will not,
by the time
Devendra-
they are cleaning it,
Ravinder, it is not done as faster than angioplasty, but it was done in a recorded time. For angioplasty can be done in 3 or 4 minutes. We will not
No,
accept that statement.
But CTOs,
We
you
don't-
take 2 hours.
we don't want to
But
do it fast.
wonderfully
We want to do it
demonstrated.
safe.
Actually, we can see that your skill level is excellent, no doubt about it. And it is very well demonstrated. I was telling Ramesh,
Thank you so much.
the skill is
This is one more thing which we want to discuss there on the platform. Now that we are doing only just one AngioSeal, one ProGlide, maybe we can have opinion from experts, Dr. Kodali, Dr. Saurabh Gupta. So we're doing just one pro glide, and then can you focus here on the groin, please? No, come down. So just one pro glide from 3 to 9 o'clock position. And then if there's a pulsatile flow, can you focus on the groin? We would use an 8 French angioseal. I mean, this is our experience. What we have noticed is the vascular complication has gone down. We don't see any more pinching. Sometimes if there is any bleeding after one pro glide, we have converted a hole to a 2 French hole and somebody holds manual pressure and we would reverse the heparin with protamine. So you can see just with one pro glide, there is no pulsatile flow. I'm not even going to use an angioseal here. We'll go ahead and remove the wire. Okay, and show us the DSA, please.
Which one?
Yeah, that,
Right groin. Come
Ravinder,
down.
that's become a default approach as
Can
well.
fluoro be removed and groin be bigger? I think now it's stopped totally. Thank you. I think you can see it.
Can.
Well. Thank you.
Yes.
Are you
Okay,
focusing
show the
on the filter
DSA, show
once
me
before
DSA
we
about,
move
please.
away from? Very good. I think with one.
I will.
Itself, you have,
ऊपर
stop.
pigtail दिखाना.
What is your practice? You are
Okay.
using 2
Come
or
down.
No, we're down to 1 now for the last about a year and a half. And then I think in about 50% of the
Inject.
cases, I find that we have to use an angioseal, but the other 50% looks just like this.
Okay. I think with one device.
So you can see the DSA with just one angioseal.
Yeah, perfect.
One pro glide. Let's focus on the filters, please. And then we also do a cerebral, the neurological assessment before patient leaves the cath lab. Otherwise, there is no benefit of doing a conscious sedation TAVI. So Prashant is going to talk to her and just ask her to move all upper and lower limbs. Don't put anything in the basket just to show.
No, it's okay. I think sometimes it's difficult to find, we understand, but still I think you showed it, Sentinel filter deployment very well. Congratulations to the entire team, great demonstration. And with any words, last words, we move on
Thank
to
you.
the center. Thank you, Ravinder. Excellent demonstration. Dr. Sai wanted to show
Thank you so much, sir. Thank you from our team.
Thanks for agreeing to do live for us. And thank you.